All right, well, about 70 participants. That seems like a good starting place. Thank you, everyone that has joined us today. We've tried to organize what we think will be a really interesting set of presentations today related to our topic, which is new findings on blood lead levels in Georgia, cookware contamination, and a lead burden index tool. All of these being discussed basically for the first time here. My name is Drew McCarter. I'm the president of the nonprofit organization Pure Earth. We work to protect people from exposure to toxic pollutants in low and middle income countries. We're really delighted to be joined today by our co-host, Megan Horton from the International Society for Children's Health and the Environment, or ISCHE. I've just learned that's how they like to pronounce the acronym. Megan, would you like to introduce yourself and ISCHE a bit further?
Sure. Good morning. Thank you, Drew. And thanks to you for Pure Earth for the opportunity to join this exciting webinar series. I'm a professor in the Department of Environmental Medicine and the Institute for Exposomics Research at the Icahn School of Medicine at Mount Sinai in New York. My research integrates environmental epidemiology, neurodevelopment, and exposomics with a particular focus on how early life exposures to complex chemical mixtures, air pollution, metals in particular, how they influence brain health and development across the life course. I lead several NIH funded studies that combine biomarkers like naturally shed deciduous teeth or baby teeth with high dimensional analysis to uncover mechanisms linking the exposome to neurodevelopmental outcomes. I am the current president of the International Society for Children's Health and the Environment, ISCHE. ISCHE is a global interdisciplinary network dedicated to advancing research, policy, and advocacy to protect children from environmental hazards. I look forward to learning from and connecting with this panel and with this community. Thank you.
Thanks, Megan. And Megan's going to tell us more about our kind of topic and presenters today. But before we jump into that, just a couple of quick housekeeping notes. So before we get started, please direct your questions to the Q&A box at the bottom, not the comment box, but the Q&A box. And we will be reviewing those throughout the webinar. And then we'll have about 15 minutes at the end where presenters will answer questions live if we have not already answered them in the chat. We'll also try to be answering some of them in the chat. So with that, Megan, back over to you briefly to kind of introduce our topic further.
Today, researchers will present new findings on lead exposure, including a new metric, the Lead Burden Index, which can help quantify the gross impact of lead exposure across regions and support governments, funders, and international agencies in prioritizing cost-effective interventions. Also, an initial post-intervention blood lead level study in Patti, Georgia. And third, a comprehensive analysis of leachable lead in aluminum cookware from 25 countries, revealing continued risk from consumer products. Let's start with the latest findings in lead in aluminum cooking pots in low and middle income countries. Our first speaker is Dr. Gordon Binkhorst. Gordon is a senior technical advisor for Pure Earth. Gordon?
Okay, is that better? Sorry about that. Good morning, everybody. So today we're going to talk about leaching lead from aluminum pots and pans. So the results of this study was recently published in the Journal of Hazardous Materials, coming to a newsstand near you, or easily available on the link at the bottom for free on the web. Why do we care about lead in aluminum cookware? And I just want to bring up the case of the Afghan refugees in Washington State in the US. In 2014 and 2016, the health department determined that the children had quite elevated blood lead levels, about half in the 5 to 9 microgram per deciliter range and about 11% in the 10 to 19. Very concerning levels, and the health department determined that the cause was aluminum pressure cookers from Afghanistan. So just to highlight that this is a real problem affecting real children, even in the state of Washington. So the leaching study that we're going to talk about, the genesis of it was the rapid market screening study that Pure Earth did, where we collected over 5,000 consumer products and foods from 25 lower and middle income countries. And the report of that is on our website. And amongst those 5,000 items were over 500 metallic foodware items, which included cooking pots, but also plates, cups, and utensils. And we screened all of these 500 items for total lead using an XRF, and we found that over half of them had concerning lead levels above 100 parts per million. It's a reference level that we're going to circle back to later in the talk. We had a high of almost 100,000 parts per million, or 10% lead. So again, very high levels of total lead in these cookware items. Today we're going to focus on aluminum pots and pans, which are shown here from just six examples of the, I think, 115 pots and pans that we used for the study. So this is just to put things in context pictorially. So you may ask yourself, why is there lead in aluminum pots and pans in the first place? And that's really a question of the feedstock that they make the aluminum pots and pans from. And they don't just include your Diet Coke cans, but they also include things like engine blocks, radiators that are soldered together with lead, blister foils, a whole variety of deleterious materials. So in addition, we've recently found out from our colleagues in India that a lot of the smelters use a flux to ironically remove impurities from the molten aluminum, and that flux actually contains lead as well. So getting back to our aluminum pots and pans, like I said, total lead in all of these. This is what the results look like. And you can see that over 80% of our pots and pans had over 100 parts per million lead in them. And I think about 4% had over 10,000. Looked at slightly differently in a pie chart. This is maybe a little bit more visually appealing. Again, just over 80% in the over 100 part per million range, and very high total lead levels. So what does this mean? We have a lot of total lead in cookware, but what does this mean in terms of exposure to it? And it's a question of hazard versus risk. The total lead presents a hazard, but the risk is only if it leaches into your food. And in order to really determine that, we did leachate studies on selected pots. I think 100 pots for a bigger study, and about 15 pots we did some initial work, which I'll discuss. And that's how we quantify how much lead potentially can leach into your food. Just as an example, this pot from India had about 900 parts per million total lead, and the leachable lead was about 60 parts per billion, which is about 6 times higher than the drinking water standard. But we'll get back to the results shortly. So when we talk about leaching, there are many different ways one can leach a pot or a pan. You can use real food, like rice, curries, tomato sauce, etc. Or you can simulate it using things like acetic acid or vinegar, which is supposed to mimic the acidity of a tomato sauce. And there's advantages and disadvantages to both. And even simulated leaching, there are many different factors at play, which we're going to discuss. Like you can use acetic acid, you can use water, palm oil that people cook in, you can do it at room temperature, you can heat it, salt versus no salt. I mean, we cook with salt, so should we be using salt in our leachate medium? How long we heat the material, how long we let it sit at room temperature, old versus new pots. All of these things will impact the lead leachate concentrations. So we did some initial research into some of these questions because we wanted to come up with a way to test the bulk of our aluminum pots and pans. And the biggest thing we found was heated versus unheated. We left acetic acid in pots for not hours, but days. And then we also heated them. We boiled acetic acid for about about 5 hours total, and collected samples. And what we found was the heated was 2 to 3 orders of magnitude higher than the room temperature. To put this again into a frame of reference relative to our 10 part per billion drinking water standard, 10 to 30 in the unheated and 200 to 20,000 parts per billion in the heated leachate. We also looked at replicability. If we took the same pot and subjected it to boiling for 2 hours, the acetic acid, do we get the same results over and over again? What we found was no, we don't. And this has some bearing on our study. And also we'll discuss why we didn't get good replicability later in the talk. But what we found in the lower graph was leachable aluminum, stayed fairly consistent each time. This is 7 pots that we did 6 replicate or repeat leachings of. Again, the exact same technique over and over again. So the aluminum stayed about the same. It went up and down a little bit, but what was most surprising was the lead varied quite a bit. It went up and down significantly, and overall it went down with each successive leaching. So again, we'll come back to these findings as to why we thought this happened. But in our study, we worked just with new pots and we leached them only once. But this has bearing for other parts of our research. What we also found was we had some old pots from India. And what we found was the old pots tended to leach way less lead than the new pots. And again, we'll talk about this a little later. And lead gets depleted, etc. But for any total lead concentration, the old pots leach less than the new ones. And then we also looked at salt versus no salt in our leachate medium. And what we found was adding salt marginally increased the amount of aluminum that leached, but it actually decreased the amount of lead, but not very significantly. So then we selected a leachate technique or methodology for the 100 pots and pans, all new from these 25 different countries. And basically, in short, we filled them to 80% capacity with 4% acetic acid, and to mimic tomato sauce, boiled it for 2 hours, collected samples, and tested them for total lead and total aluminum. So now we can talk about total versus leachable lead results. This pie chart is leachable lead. The former one I showed you was total lead. And you can see that about over half of our pots leached lead into the acetic acid that was above a drinking water standard of 10. We'll get to some of the higher measurements in a moment. So, and this was our graphical abstract for our paper, just how we went from total lead and pots from a marketplace in Ghana to leachable lead in laboratory studies, and the pie charts representing both. So, getting back to total lead versus leachable lead. This is x-axis is total lead, y-axis is leachable lead, and please note that this is a log-log plot. And as you can see, the data does follow, a general form of the higher the total lead in a pot, the higher the leachable lead is in general. So we see that trend, but we also see quite a bit of scatter. At any particular total lead concentration, say 1,000, you can get something in the leachate that is below the drinking water standard or several hundred parts per million. So orders of magnitude higher than the leaching standard. And that scatter, from a scientific standpoint, is not great. It doesn't show good predictability. That's also reflected in our correlation coefficient of less than 0.3, which is kind of embarrassing in a way in terms of does this correlate well? But we'll talk more about that also in a moment. I want to draw your attention to the lower part of the graph, circled in red. We had about 20 pots with total lead that was 100 parts per million or less, and only one of those pots leached above a drinking water standard. This is the genesis of our 100 ppm reference standard for total lead, meaning that if you're below 100 ppm total lead, then the likelihood of leaching above a drinking water standard is pretty low. And again, this is using a very aggressive technique that's probably more aggressive than actual cooked food. Okay, so that wanted to draw your attention to that. Now let's get back to the scatter. So again, we're not happy with the scatter. We would like it to be much tighter. It's not, and why is that? The first reason is we're using an XRF for total lead measurements, and we're taking an average of each pot. Sometimes the average was taken of, say 5 or 10 readings on the inside of the pot. We couldn't always get on the inside of the pot. So we had to use readings on the outside of the pot, which is not in contact with the food, or the leachate medium in this case. So that's one reason for the scatter. All of our pots were of different sizes and different shapes. And that also has bearing because you have different surface to volume ratios, for example. So there's many different factors that lead to this variability in scatter. So it doesn't really disturb me at all. And one of the other things is the manufacturing technique, how these pots were made. And that one, I will just draw your attention to these pictures here. The pot from Ghana on the left is cast, meaning it was made from molten aluminum that was poured into a mold and allowed to cool slowly. Then the mold is broken off and voila, you have a pot. The pots on the right were wrought pots, meaning they were mechanically made. The aluminum ingots or whatever form it was pushed out into a sheet, and then the sheet was molded through spinning or hammering into the shapes that you see here in cold conditions. Okay, so very different manufacturing techniques, and it turns out we had about 37 cast pots and about 63 mechanically made or wrought pots in our study. And we then separated our scatter plot here into wrought versus cast pots. And initially what you can see, the blue line at the top are the cast pots, and for any given total lead concentration, they tended to leach more than the wrought mechanically made pots. You also see that there's less scatter in the plot, and our correlation coefficient increased to the 0.6 range, which is thankfully a little bit nicer. So we can see that the manufacturing technique definitely has some bearing. And why is that? So we looked at these pots under a scanning electron microscope to see what's going on as we leach them. And we have two new pots, and the bottom one is an old pot from India. And again, we cut these pots. We're looking at the cross sections of these pots right now. The two on the bottom were wrought or mechanically made. And you can see in the photographs that they actually have a pattern. There's a structure to them. The lighter gray is the aluminum matrix, and then all these darker things that you see are inclusions, which include lead, iron, silicates, etc. And there's an actual layered structure in this versus the cast at the top is very different. And those were, again, the aluminum was allowed to cool. The aluminum would have crystallized first with a higher melting temperature, and then the lead gets deposited around the aluminum as it reaches its melting point. Okay, so these are very different, different manufacturing techniques, but also different structures. And now, when you subject it to leaching or cooking, the acetic acid is attacking and dissolving the aluminum, and it doesn't do it uniformly. You can see in these cross sections that it picks selected areas where it gains a foothold, so to speak, and tunnels down into the aluminum pots and pans. And you can see that most dramatically in the old pot from India, which is, because it's old, it's gone through almost a quarter or a third of its thickness in some areas of the pot, and seems much less in other areas of the pot. And you can also see in this lower photograph that it finds preferential pathways. It doesn't do it uniformly in cross section or in plan view, but it does it. It finds the most dissolvable areas and goes there first. So then you have to ask yourself, during any particular time frame when you're leaching this pot and it's dissolving and attacking the aluminum, is it coming into contact with impurities, including lead? Okay, because this is important. Every time you do it and you dissolve more aluminum, you may or may not get more lead out of it, which is, again, part of the reason for the replicability plots that I showed you earlier. And it's also, I think, part of the reason we see high variability in the total versus leachable aluminum pot. And just to put things in frame of reference, you see this 50 micron bar here. That's the same on all of these different things here. 50 microns is about half of the width of a human hair. Just so we're looking at this at pretty close up. This is just another electron micrograph of another cross section. This is even closer. This scale bar here is 10 microns, or about 10 the width of a human hair. And again, the darker stuff is the aluminum, the lighter stuff is the inclusions. The lightest ones here are the lead. Okay, so they're sort of heterogeneous at this scale anyway. They're sort of heterogeneously distributed in the matrix. So now you superimpose this on, as the leachate is attacking the aluminum, is it coming into contact with the lead nodule or not? Okay, again, a reason for all the variability that we see. So we have total lead, we have leachable lead, but what does this mean in terms of exposure and the impact on total on blood lead levels? And in order to look at this, we use the EPA's all ages lead model to model what a resultant blood lead level would be for consuming leachate concentrations that we found in our study, which is basically from 0 to 3,000 parts per billion, or 300 times the drinking water standard. And the ALM simulations incorporated decreasing gastrointestinal absorption with age, and food consumption was constant for adults greater than 20, but was less for younger and younger children. And what we found was some concerning blood lead levels from this modeling. This is based on consumption of 250 grams per day for a 10-year-old, and as I indicated, less for children, younger children, and slightly higher for the adult modeled here from in the 25 to 30-year-old range. What you notice here is the adults were impacted and older children were impacted more than the younger children, which is contrary to what most people would predict, as it's, I think, commonly that children absorb more lead than adults. So you would expect a reverse of this, but this is because we adjusted the food intake. A 1-year-old certainly eats less than a 6 to 10-year-old, and that overwhelms the absorption issue. So again, very alarming potential blood lead levels, and in fact, they're sort of consistent with what the Washington State Afghan refugees showed in terms of it's within the right ballpark anyway. That might be happenstance. They may have had other blood lead level impacts, etc. But at least it's similar and consistent. So it's important to note with the modeling issue that there are some limitations. You know, it assumes daily ingestion of food represented by boiled acetic acid for 2 hours, which is a relatively aggressive leaching medium. It's not representative of the bulk of foods consumed, like rice, corn, and cassava. And we also studied it in new pots, which leach proportionally more than old pots. And also people use different cooking times, different pots in the household, scale buildup, lots of different factors affecting. And this really gets down to, you know, when we leach a pot using 4% acetic acid, we're trying to show that it's safe from a usage under any condition, but it doesn't well represent what people are potentially becoming exposed to by cooking things like rice and corn. Okay, so that's an important consideration, and that's why additional research is really warranted to sort of figure out what that might look like in terms of how much lead is leaching out into actual foods that are consumed and make up the bulk of people's diets. So just in summary, heating was very important, 2 to 3 orders of magnitude higher. 100 ppm total lead reference level seems good based on our drinking water standard. Higher total lead yielded higher leachable lead, but a lot of scatter, which was improved upon by separating cast versus mechanically made pots. The SEM EDS work shed some light on some of the mechanical aspects of what's going on with these pots and why we see the variability that we do. And the BLL modeling showed potential impacts, but the 4% acetic acid may overestimate actual exposure relative to foods consumed. So again, the acetic acid might be good for certifying cookware as safe under any or most cooking conditions, but overly aggressive with respect to actual exposure. I'd just like to thank my colleagues who helped with this project, as well as James Brown, our funders. So thank you very much, and we'll certainly obviously take questions, I think, at the end. Thank you.
Thank you, Gordon. And wild that we have been using lead for over 5,000 years. Aluminum cookware has been popular for over 100 years, and we are just now really starting to scratch the surface of how lead is getting in and coming out of all that cookware. Look forward to hearing more soon. Next, we have a presentation on new blood lead level survey results from the country of Georgia. Within the lead community, Georgia is often heralded as a really interesting case for a country that's made enormous progress. And today we're going to hear from Ekaterine Ruadze, who is the Monitoring and Evaluation Officer for the National Center for Disease Control and Public Health in Georgia, and Ailita Sargsyan, who is a technical advisory board member for Pure Earth. And they're going to be presenting findings from a new paper called Assessment of Blood Lead Levels in 2 to 7-year-old Children in Poti, Georgia. And this is a pilot study of environmental lead exposure sources, as well as findings from another assessment in Guria, Georgia. So, ladies, over to you.
Thank you very much, Drew. Good evening, everybody. So it's evening in Georgia. And me and Ailita, we will be presenting the lead exposure source identification project in Georgia, which was conducted in collaboration with the UK Health Security Agency and Pure Earth. I will talk a little bit about the background. The National Representative Survey of 1,578 children, which was conducted in 2018, revealed that 41% of Georgian children had blood lead level at or above 5 microgram per deciliter. The highest prevalence, ranging from 61% to 85%, was observed in the western part of the country, which is actually the coastal region. In contrast, children living in the eastern part of the country showed comparatively lower prevalence. It should be mentioned that even before the survey, smaller scale studies, also revealed that there was a high BLL among children 2 to 5 years old in Georgia. Well, in response to these findings, Georgia implemented several public health interventions and research interventions. So we established a state program in 2019. We also designed and piloted the lead surveillance system from 2022. We established a chemical risk factor laboratory and capacity building activities with the support from UNICEF and UK Health Security Agency. And in parallel of these activities, environmental agencies implemented interventions to reduce lead contamination in spices. Studies documented that spices in Georgia contained high lead level. For example, the market assessment, which was conducted together with Pure Earth and environmental agencies from 2020 to 2022, and they collected 20 spices from 29 cities, about 765 spice samples. This investigation revealed that there was a high lead level above Georgia reference level, which is 5 microgram per deciliter in 4 to 6% of spices. Vendor interviews, which was also a part of this market assessment, revealed issues related to supply chain and intentional adulteration of spices. These findings contributed to stricter food safety regulations and regulations which was implemented from 2018. Well, the first study, which was conducted in collaboration with UK Health Security Agency, was in 2019. The aim was to develop the lead isotope ratio method to identify the most likely sources of lead exposure. We investigated 36 children, which was previously identified in the mixed survey as having blood lead level above 10 microgram per deciliter. We collected some spices, soil dust, and paints, and isotope ratio analysis was conducted in UK Health Security Agency laboratory. This study found that environmental samples such as water, milk, and flour were not sources of lead exposure, and dust, soil, and spices and paint seemed to be a source of lead exposure. After this study, we implemented another study, which was started from 2023 in Poti, with collaboration again NCDC, UK Health Security Agency, and Pure Earth. And I later will talk about the Poti findings. And after the Poti findings, Poti study, I will continue talking about Guria study. Please, Alita.
Thank you, Eka. So after the mentioned proof of principle study, the pilot study was conducted in the Black Sea port city called Poti. And where the main objectives were, first of all, to describe the current range of blood lead levels in the children aged 2 to 7 years, measured during October and November 2023. Secondly, to see whether the findings of the study will be similar or they will differ from those of mixed 2018. And third, to explore possible sources of lead exposure using isotope ratio analysis. All these efforts were embedded within broader capacity building activities, which were led by NCDC and supported by the NCDC's international partners. The target population of this study were the children between the age of 2 to 7 years, as I already mentioned, which aligned well with the age group assigned by Mixed 2018 survey. 63 children from 50 households participated in the study, and all these households were chosen and selected from across all the regions of Poti to ensure broad representation. These households were chosen using a probability proportionate to size method. And here on the map, you can see the 4 regions of Poti and the households that were chosen from these 4 regions. In addition to the blood testing, environmental samples also were collected. Soil, household dust, spices, and paint, wherever they had peeling or chipping surfaces, were collected and then tested using ICP-MS. And besides this, salt and sugar samples were collected and tested using XRF, but however, this didn't find any lead contamination in sugar and salt. Here in this table, you can see the distribution of blood lead levels among the mentioned 63 children that were sampled in Poti and divided and presented separately in the districts. As you can see, the blood lead levels ranged from 0.6 to 15.3 microgram per deciliters. And the overall geometric mean was 2.0 microgram per deciliter. Only 2 children among 63 had blood lead levels higher than 5 microgram per deciliter, and 13 children, which was around 21%, had levels above 3.5 microgram per deciliter, which is accepted as reference level by CDC. Here you can see the comparison of Poti result with Mixed 2018, the geometric means. And in Mixed 2018 from Poti, there were 38 children, and the geometric mean was 7.5. And in Poti study, as mentioned, was 2, which is 70% reduction of BLL. And here it is shown the distribution of lead concentrations in the environmental samples. And here we can see that highest proportion of samples that exceed the reference level came from paint with around 67% above the threshold. And then paint was followed by household dust with around 44% of samples exceeding the guideline, and then by soil. Spices showed lower exceedance rates, only 2.3% for spices. And then finally, lead isotope ratio analysis was done, which showed that for the child with BLL above 10 microgram deciliter, dust and soil were potential sources. And for one child with BLL above 5 microgram per deciliter, only dust was most likely the source. Eka? You're on mute, Eka.
Okay, I'm sorry for that. Okay, the potty pilot study was followed by a larger representative study in Guria, a region in western Georgia. And a study was conducted from October 2024, from August to October, in 2 to 7-year-old children living in the region. So we included all three districts of the region. We also aimed to compare these findings from the mixed 2018 survey findings, which just like we did for potty. And of course, we also wanted to identify possible lead exposure sources using isotope ratio analysis. Well, because in this case we wanted to make sure that we have a representative study in Guria, so our sample size was 300 children, and that some calculation of the sample size was based on stratified random sampling approach. And all these considerations, such as margin of error, type 1 error, response rate, everything was taken into account. Data for the data collection and for sampling of the children, we used data set which was received from National Health Agency. For the random selection, we used data 18, and we followed the protocol which defined urban-rural location, sex and age stratification, just to make sure that we have boys and girls included proportionally, and the age definition, the distribution was from 2 to 5 years old, as well as 6 to 7-year-old children are also included in the study. Based on the previous findings, we only collected 4 types of environmental samples, such as dust, soil, spices, and paint. And on this map, you can see the households, and this concentrated red dots indicate urban areas, and you see the 3 districts like Chokha-Tauri, Lanchhuti, and Ozurgeti, and all these scattered red spots were villages, and you can see that some of these red spots are quite distant from urban areas, and these are actually mountainous parts of this region. Eventually, we included 301 children. Most were from Ozurgeti region, followed by Lanchhuti and Chokha-Tauri, reflecting the population distribution of the municipalities. Blood lead level ranged from 0.79 to 14.69 microgram per deciliter. Only 14 children, 1/4, had blood lead level at or above 5 microgram per deciliter, which is 4.6% of all 300 children. And 12.3% of children had blood level at or above 3.5 microgram per deciliter. And only 3 children had blood level above 10 microgram per deciliter. And on this graph, the same as we did for POTI, we compared the result geometric mean, which we calculated based on mixed survey and the our Guria study, and you can see the huge difference between them. And I would like to say that in mix, there was 152 children included from Guria, and the minimum blood level was 0.9 and maximum was 33. And in our case, the maximum was 14 microgram per deciliter. And you can observe a 75% decrease in geometric mean between these two studies from 2018 to 2024. So we did the same thing as we did for POTI. And in this graph, you can see the exceedance percent for another samples to the reference values. And when paint samples exceeded the highest reference value, the reference value for Georgia is 90 ppm. Okay, and then it's followed by soil samples, and then blood and dust was lower, but the lowest was among spices. Well, it's notable that, and it should be mentioned here, that in POTI, we had more samples, more dust samples that exceeded the reference value compared to the Guria. And in spices, in Guria, we had much lower percent of exceedance compared to POTI. In POTI, it was 2.3% and exceeded the reference value, and here we have 1.5%. And in case of dust, 12% exceeded the reference value, and in Guria, it's only 4.5% exceeds the reference value. And if you look at this isotope ratio analysis for these 10 children, for these 3 children, for which blood level exceeded the reference value, we see that it's actually the spices and dust. And spices, despite the fact that concentration in spices was low, they still showed isotopical similarity with blood lead together with dust. And in this case, soil is quite distant from dust, from blood, sorry. In this case, you can see that it's blood and spices. The yellow are spices only. And in this case, you see that it's spices and, a little bit of soil, maybe. So spices still appear to be a problem, even though the concentration became much lower, that concentration than it was 3, 4, and 5 years ago. So in conclusion, following interventions to control blood exposure in Georgia, blood lead level and incidences of exceedance above blood lead limit value in Georgia children have lowered. And for Georgia, we have 5 microgram per deciliter. That's our reference value. The blood lead level still remains a problem, especially if we compare it to the CDC reference value, which is 3.5 microgram per deciliter. Okay, we noticed the dramatic reduction of lead concentration in spices, but isotope ratio analysis still shows similarity with blood lead. Well, we actually observed that there are different percent of exceedance in different regions. In this case, we can see POTI and Guria. POTI is a city in the Samegreelo region. Guria is a region itself. Yes, we understand this, but from this we generated idea that maybe Georgia, even though Georgia is a small country, there might be some predominant sources be most important in different parts of the country. And of course, future work is needed to address the national incidence and exceedance in the children. We do notice the reduction, but We don't have a representative studies to really prove this reduction of blood lead level. And we are still looking to do the questionnaire analysis, that's the future work, and to do some avalid isotope ratio analysis for other children. For children, those blood level did not exceed the reference value, 5 microgram per deciliter or 3.5 microgram per deciliter. Okay, and this is our future work to complete the Korea analysis. And of course, I'm very grateful to each and every person who participated in this collaboration. I'm very grateful to UK Health Security Agency colleagues, Pure Earth colleagues, and NCDC colleagues, especially our laboratory personnel and our interviewers. Those did amazing work to collect all this information. Thank you very much. Sharing.
Thank you, Ekaterine and Alida. This work offers valuable insight into how local data collection can inform exposure sources and source apportionment and support evidence-based action to protect children's health. So thank you for your presentation.
Thank you, Meg.
For our final presentation today, Richard Fuller, founder and leader of the Innovation Lab for Pure Earth, and Bruce Lanphier, professor of health sciences at Simon Fraser University, will present on a new lead burden index tool. Bruce and Richard.
Good morning, good evening. Hello, everyone. Bruce, I'll go first and show some of these tools and then pass it over to you, okay? Let me just get this going. All right. So thanks, everyone. Because it's actually quite a small, simple idea that we'll be presenting here, this is going to be a short presentation. Nothing extraordinarily complicated in it. But I did, before starting to talk around the work on lead burden index, just note that within the Innovations Lab, and hopefully in more of the research as time goes on with Pure Earth, we're going to be moving for blood measurements away from micrograms per deciliter and instead going to micrograms per liter. So 3.5 micrograms per deciliter would then become 35 micrograms per liter. And we're noticing that more and more researchers are adopting this standard as time goes on. And there's two very good reasons for it. The first is micrograms per liter is equivalent to parts per billion. And most environmental contaminants are measured in parts per billion. So it helps to be able to look at these things in contrast. But perhaps more interesting is that the messaging of saying, hey, you're at 35 micrograms per liter is stronger than saying, hey, you're at 3.5. So if you can go to a group of people and say, we're going to take you from 45 down to 20, that sounds better than saying we're going to take you from 4.5 down to 2. People just approach bigger numbers with more interest. Okay. So the question that has been in front of us for a while is, how do you compare different lead poisoning scenarios? And then as a result, how do you work out which ones you should invest in or approach first? So here's a few examples. A battery recycler might have 2,000 people in its very direct impact group, and they may be increasing BLLs by 200 micrograms per liter. Notice there, that's 20 micrograms per deciliter. Sorry, 150, I'm sorry. And that is, a terrible problem, of course, because at 150 micrograms per liter, you've got all sorts of terrible impacts that are going on. But you might also have leaded pottery, as we do in Mexico, with a lot more people affected, but it's only 10 micrograms per liter that has that impact. Similarly, spices might have fewer, but have a higher blood lead impact. So all of these numbers can make it difficult to be able to compare lead projects. So especially, as I said before, for donors and for governments. And with all other factors being equal, the cost of doing the project, its viability, its chance of success, the amount of government support, all the rest of it, with all those being equal, people will want to fund or implement projects that will make the most difference. That's what we all want to do. How do we spend our money as wisely as possible to make the most difference? So trying to merge these two different issues. One is the amount of BLL that's impacted and the number of people that are impacted is what we're doing with this short paper in British Medical Journal on Global Health. So this paper is really a first order tool, quite a simplified tool to be able to give a number we're calling the lead burden index for different types of projects or governments or nations and the rest of it. And it's simply the average blood lead level of a particular population multiplied by the number of people who are within that population. So nothing more complicated than just multiplying the two. And if you're looking at average blood lead levels that are between 0 and 6 or 7, actually the health outcomes that are associated with those are reasonably linear. So it's not a bad tool to be able to use to be able to project net benefits for doing these issues. And we will get criticism for pointing out that there are different profiles for different age groups and all the rest of this. And they're very valid criticisms. But as a first simple starting point to be able to create something that measures total impact, I'm using the KISP principle. Keep it simple, please. This is a sensible way to do it. So let's have a look at lead burden in different circumstances, just to show how it looks. So if we look at the entirety of the world, which means taking the average blood lead level from IHME data and multiplying it in each country by the population of that country, the total number of these index, and by the way, the metric is CPBLL, cumulative population BLL, 305 billion is how much lead problem we have in the world. If you compare that, the US has a little bit more than 1% of that. Obviously, we've got low blood lead levels here. But India has 80 billion, about 26% of that particular amount of impact. And then, of course, we can look at projects too. So I mentioned leaded glaze in Mexico. If a project was successful in getting rid of that glaze, it would create a benefit to the country of around 1 billion CPBLLs. And as another example, the wonderful work that happened in Bangladesh with spices that were contaminated being halted. This was work done by Jenna Forsyth and others. That reduced CPBLLs by about 0.5 billion in that country. So this is a tool then to be able to compare and evaluate. But there's one more step that we'll move on to in all of this. And Bruce will give a little bit more information on this, I think. And that is that, where do I go forward in this? Why isn't it working? Ah, there we go. That is, we can take the lead burden number and doing a little bit more work on it with an indication of the dose response curve and the population private and more, we can create a way to be able to evaluate how many premature deaths are occurring because of that particular amount of lead burden. So we're going to be doing, we're actually most of the way through doing this at the moment. It'll be finished up this summer. And what we'll put out will be another journal article along with an Excel model that people can take and use themselves. They can play with it, they can adapt it, and then help to make their own assessments about how big the impact would be. Because what's really useful is not just that you go back to the Minister of Health and say, hey, we can save 1 billion CPBLLs by getting rid of the lead in Mexico, in the pottery in Mexico. But what's more powerful is if you can go back to him and say, hey, we can reduce 20,000 deaths a year in Mexico. That's how many premature deaths are associated with that amount of CPBLLs in Mexico. And similarly, a similarly large number in the number of IQ points that is lost. So with this next step, I think we're getting a really powerful way to be able to provide that first order estimate of just how much harm lead causes. And with the cost for an intervention integrated, we can give really strong numbers in terms of cost benefit. So I will stop there and ask my dear friend Bruce to jump on right on in.
Thank you, Rich.
Here we go.
Okay.
Good.
So I just wanted to follow up and first start out by saying, I think this is a great idea to find ways to begin to help people prioritize what countries should we be focused on, what sources should we be addressing first, how do we prioritize this when there's so much lead around. And I think one of the main things that keeps us from acting on lead historically is the problem seems to be overwhelming. So if we can help to develop a way to prioritize it within countries and globally, I think it could be really powerful. One of the ideas I think that we need to take from what Rich, and I have to look at this because the acronym is just going to make me nuts, CPBLL, is how do we help market this? How do we make it accessible? And I think the first thing is we've got to think carefully about the name. If there's a name that you can't pronounce, you have to keep going back and checking on it. What does this mean? I think that's going to make it more challenging. I think something like the lead burden index is simpler, at least for English speakers. I can't speak to others, to get our heads around coming up with visual images. So here, my brother and I put together just an idea for how you might come up with a logo or icon, and we've got a drop of blood with the globe in it. That might be something that people could begin to recognize. And so taking this idea, making it into a visual document, a living document, is going to be an important part of the process. So the idea of the lead burden index has a lot of merit. You can almost immediately look at a map, and you could do this, of course, within states of India or the United States or provinces around the world. And that could even help you within those smaller geographic areas. And here, of course, once you get used to the colors, you're going to hone right into India and say, we really need to do something about India. And already this paper has started to get people thinking. 2 weeks ago, I was contacted by the Clinton Health Access Initiative, CHI, in India, and they said, we need to do something. What should we do? Right? So that's really powerful. We're already seeing signs. On the flip side, we might find countries that say, I've got a low lead burden index. I don't have to worry about it. I should keep focusing on diarrhea. So we need to be able also to provide information looking at the mean blood lead levels so people can toggle back and forth. What's the average blood lead level in my country? And that average, based on Jeffrey Rose's work, we know will give us information about the prevalence over 3.5 or 5 or 10, whatever we want to use it for. And so being able to toggle back and forth is quite powerful. Rich made a powerful point about microgram per deciliter, and he's absolutely right. And I fell back into microgram per deciliter. But we need to keep working on changing that, including for ourselves. So being able to take this and be able to look by population, by the numbers, and then ultimately, although we didn't try to do this for this presentation, how do we bring in the sources and the feasibility of addressing those sources? Right now, for example, we're very excited about trying to get rid of ongoing uses or sales of lead paint, partly because it's feasible, it could be done within 5 years perhaps, and the legacy of lead paint just goes on and extraordinarily expensive to deal with. So being able to look at both the burden and the mean blood lead is going to be important. And then Rich and I have already started to talk about how could this be built up for other contaminants. And so here you can see the same idea for mean urinary arsenic levels by country. You can measure arsenic in other ways, but it's relatively easy and pretty typical to use urine. So we changed the icon from a blood red to a urine yellow, right? So you could have a panel of different contaminants on your screen, and you could go from lead to arsenic, cadmium, whatever contaminant you want to look at. So the idea of being able to pull this into a tool that's usable in the field, that's simple to use, that can be updated regularly, and I think it has a lot of potential to give us kind of a roadmap or a way to take a strategy and map it out country by country, or even ideally in the future when we have more data, even state by state or province by province. Now, what we didn't try to put into any graphical form, but I absolutely agree with Rich that we could take this and relatively easily add on the burden of disease by IQ loss, by coronary heart disease deaths. That would be relatively straightforward when we have the data. Perhaps a little bit more challenging, but very doable within the same kind of a app or website would be to have another series of pages that allow us to look at the various sources and identify both the ease of eliminating these sources and the overall impact of focusing on either lead glaze, for example, or paint that's already on houses. And so this could offer us a really exciting tool to use to take the theory, the concept that Rich and his colleagues put together, and find a way to make it, to implement it. Thank you.
So just before we turn it back to Megan, I do want to note that there is an excellent website that has a lot of this data and resource on it. It's leadpollution.org. And you can see their lead burden indexes for each country, as well as average blood lead level from IHME data as it's currently listed. IHME will soon update its own data set with the latest GBD numbers, and we'll give a new set of data that we'll update onto that website quite soon. And in the meantime, we haven't yet made the switch from micrograms per deciliter to micrograms per liter. So our bad, but we'll do it all together when we get the 2023 data, and then we'll make the change then as well. So.
Thank you, Bruce, and thank you, Richard, for your presentation. Thanks to all of you for your presentations. I'm looking forward to a rich question and answer period and more discussion. Since I have the mic, so to speak, I'll take the liberty of asking the first question. Well, first I want to acknowledge, Richard, that shift from micrograms per deciliter to micrograms per liter. That's powerful, and I think that's a very I say simple, as there's evidence that it's not simple, but a very clear way and powerful way for us to demonstrate how we can change things. My question is about the CBPLL. How does the CBPLL account for age distribution within populations? So since children are more vulnerable to lead toxicity, have you considered weighting the metric by age or by vulnerability?
It actually doesn't differentiate between age at the moment at all, because there's a couple of things in this. The first is that when one is looking at IQ loss, that's only applying to a particular group of children. I think we're choosing 0 to 10 years who will see IQ loss for exposures to lead. So in that case, to calculate the number of IQ points that are lost, we need to differentiate within the population the number of people who are at that age. But the other thing that's interesting that I want to make the point is that I have a feeling that the cardiovascular impact of lead, which we don't talk about much yet, we're still mostly talking about children. I have a feeling that might be a bigger driver for the people that make the big decisions than IQ loss for children. So you think about IQ loss, the Minister of Health, oh, they're losing 2 or 3 IQ points. Yeah, come on, that can't be that bad. But if you go to him and say, by the way, all the 60-year-olds, 20,000 and more will die. How old are you? I think that's got a better chance of moving mountains. And so I think that's an important kind of issue. Bruce, what else?
I think you captured it. I mean, you're using the 10 years up to 10 years old for modeling the IQ or calculating the IQ loss, but of course the IQ loss continues throughout our lives, right? And it might even at the other end of the spectrum. And with a little bit more evidence, we can also point to these people making the decision, the older than 60-year-olds, and say, yeah, and this might account for your dementia too. But right now we can focus on IQ loss.
Thank you both. I encourage all of the attendees to put your questions in the chat box or in the question and answer box so we can moderate them and get them to the presenters. Our next question is still directed towards Richard and Bruce. How does the CPBLL compare to dailies or other burden of disease measures in identifying priority countries? And what are the advantages of this metric over other established metrics?
Now, Bruce has just proved the point that we actually have to just always call it the lead burden index. There's too much of a mouthful not to. So actually, the lead burden index is one step before you get to DALYs. So DALYs and premature death are 6 of one, half a dozen of the other. They're all calculated at the same time, one being a year of life lost because you've died early or haven't been able to work. But we're not at that level yet. What you do is one takes the lead burden index and then the shape of the demographics within the country or a particular project, and then look at also the cardiovascular risk profile within the country to come up with DALYs and premature deaths. So it's the step before. So I think at that point, having done that, then you open the door to being able to compare cost per DALY for this project versus one on sanitation. And that's when it gets interesting. So the next step that Bruce and I are doing with Howard Hugh and others is going to be the real kicker.
Yeah, and maybe just to add, Megan, that I think there's a narrative that needs to go along with this. So maybe taking 3 or 4 countries and coming up with a narrative that can kind of describe what each of those means and put it in context. So in the US and Canada, for example, we've seen a decline in coronary heart disease that we can attribute at least in some large part to the decline in lead. But over the past 20 or 30 years, we've seen increases in many countries because of the lead having more recently been used there in gasoline and still ongoing exposure. So some way to help people understand it better with narrative or story.
Thank you both. The next question is directed towards Katerine and Alida. In the Guria study, those above 10 micrograms per deciliter, could the lead in dust come from leaded paint, or did the isotopic analysis reveal that the lead from dust is different from the lead in paint?
Well, this is what we're going to do next. So we have not done it, we haven't completed it. Well, in terms of paint, to be honest, well, I doubt a little bit because not all households had the painted walls on painted surfaces. So paint itself was not that much, let's put this way, okay? So from this reason, I think that's a very subjective thought. So we have to still do the isotopic ratio analysis, isotope analysis with and compare from where the dust comes, lead in dust comes. So, but just because the paint itself, is not that used on some households, have nothing painted. Yeah, so I don't know. So maybe not. Yeah, we have to do it. We have to analyze it. Yeah. So it's
Wasn't it
coming.
the spices, Ika, that was the main
Sorry?
change? Wasn't it the spices that was the main change in Georgia?
Yeah, main change was spices. Yes.
Ah, okay.
Mainly it was a spices problem, and we expected to be a spice problem again in Poti and Liguria, but the study findings proved against. The spices seems to be not as big a problem as we thought nowadays because of the regulations, stricter regulations what we have. But there are some other sources as well, so we still need to keep going and keep looking for. Maybe we have not collected enough samples, or we have not collected the type of samples from which these children are exposed to, because in some cases, we did not find any, in Port, for example, did not find any isotopic resemblance between the environmental samples collected and blood samples. So which means that we did not collect the source, the possible source. So still a lot of job should be done. Yeah. Thank you.
I think this leads into your answer in the prior question leads into this next question of for both of you. What do you think were the most impactful interventions that resulted in the blood lead level reduction seen in Georgia?
Thank you. That's what everybody asks. We think that was a communication campaign and public health interventions. And so what happened is after the mix 2018, so the National Center issued a letter for each participant individually and replied back, this is your lead level, what should be done, what kind of preventive measures should be taken. But also the people talked a lot in social media and in television as well. And we're very quickly after these mixed findings, we responded by having the national programs. Okay, so the mix was in 2018, and from 2019 we already established the state program. In the beginning, the state program was for only the children, which was identified in the mix to have above 5 microgram per deciliter. But if I'm not mistaken, from 2020, so it was for each and every child, which was referred by the doctor. So literally what was happening and what is happening right now is that if mother or a guardian suspect something, suspect might be some lead issue, so they take the child to the doctor, a pediatrician, or family doctor, and if doctor after the examination or interviewing, doctor suspects that could be lead exposure, so then they refer this child to do the blood lead, to measure the blood lead level. And it seems like a lot of children now in Georgia had this blood lead level, so the awareness increased. I think that could be yeah. So we cannot prove what caused, but we think that that's mainly the communication campaign and the increased awareness of population.
And also, if I may add, there were regulatory and enforcement activities against spice adulteration after it was found out that there is a spice adulteration.
Yes. So,
I think this is a very interesting example, an informative example of how there's both individual level and regulatory level interventions to reduce lead levels. Thank you both. I think there's one more before we move to you, Gordon. I have some questions in the list for you. Another one though for Ekaterine and Alita, if about characterizing the children in the population. Specifically, what is the eligibility criteria for selecting children from the households? And as the sample size is small, how does this generalize the study for the target population? And then a bit more about intervention, but I think more characterizing the population.
Alita, do you want to comment about the eligibility criteria, and maybe I will comment about generalizability of this study finding?
So for the potty pilot study, the question I think was about that. The children were considered eligible if they were between 2 to 7 years old age. Then they had lived in their current address for at least 3 months before sampling. And then the consent of the parents was obtained. And if the venous blood was successfully collected, these were the eligibility criteria for this participation in the study.
And I would add that for potty, we from household, we included all the children, those were eligible. So for example, if in the family there was 2 or 3 children from 2 to 7 years old, and they lived in this area, as Elisa mentioned, so they both or 3 of them will be included. So 3 children, we only from one family. If I remember correctly, from 11 families, we had 2 children included. For the other, it was only 1 child, so a single child. But for Guria study, we only included 1 child per family. And in terms of eligibility, generalizability, in potty, actually, we did not aim to generalize it, to be honest, because the potty we designed to test many things. And potty, during the potty pilot, what the main target was to build the capacity in Georgia to do isotope ratio, because in the proof of principle study, it was the isotope ratio analysis was done in UK, and now we wanted Georgia to be able to do isotope ratio analysis. So we, in the potty pilot, we used to see how this, inclusion criteria works, what could be the problems, what would be tested the questionnaire, and of course, we trained our laboratory staff to do the isotope ratio analysis. And so we prepared everything to do the full representative study in Guria. And for Guria, I said this is one region only, but it's fully representative in terms of sample size and in terms of sampling method. But in Potty, the good thing, even the sample size was small, we all know that, and we have no ambition to generalize it, even in the Potty or even in the this Samagrillo region. So we wanted to make sure that we include children from all zones of Potty. And all this 50 households, we selected a probability proportional to size method as whatever it includes. So you all know how to do this. I don't explain that. So that's all from our side.
Thank you both. Moving to Gordon, the blood lead concentration in adults is particularly high. Could you please share your thoughts on why that might be the case?
So it's really a function of what we modeled. The ingestion rate for it was modeled based on the ingestion rate for a 10-year-old of 250 grams per day, and we scaled it back for younger children, where a 1-year-old, I believe, was about 10% of that mass, or 25 grams per day, and a 3-year-old was about half. And it increased slightly for a 20-year-old and then was consistent. So while children do absorb more lead, it's overwhelmed by the ingestion rates that we modeled. So that's the cause of why the adults and older children are impacted or have higher blood lead levels than the younger children.
I think that addresses the second question, that your modeling approach does account for the difference in consumption between adults and infants. The question is, while adults eat more food pound per pound, infants eat more. How does that impact your model?
Well, they eat more per body mass, but so the modeling accounts for that. So it's based on the IEBK model, ALM. It's now a growth from that, and so it is age specific. Like when it models a blood lead level, it knows it's a 1-year-old or a 3-year-old or 6 to 10-year-old, for example. So it is accounted for in the model itself. There are other things that are unaccounted for, like nutritional status, calcium or iron depletion, things like of that nature. So it is still a model, it is still an estimate, but it does help put things into context.
Great point. Another question for Katerine and Alida. Although I think we kind of addressed this one, the most impactful interventions. I think that's a repeated question. So I'm going to go back into the chat and see if there's unanswered questions. There's certainly concern about specifically which spices have the highest lead burden. If you have any thoughts on which spices.
In Georgia?
Sure.
Yes, of course. Well, the previous studies that showed to be a blue fenugreek and yellow flower. Yes, 2 spices, and also the spice mixes had this showed to be the highest concentration of lead. Yeah.
Richard, there's a question for you about daily usable items available without lead contamination and ideal mitigation.
Yeah, and look, we're talking about so many different things and saying that they've all got lead in them, but it's not everything that has lead in it. I mean, we hone in just on things we know have lead in it. We'll only find that sometimes 20%, sometimes 40%, and most often in low and middle income countries have lead in it. So, and the other thing too is, we've lived on this planet for 200,000 years with a background amount of lead because it's a naturally occurring element that's quite prevalent. So we are not uncomfortable with having some small amounts of lead, probably enough for 2 micrograms per liter or some such. I think depending on where you live, it's quite easy to find products that don't have lead in them. So you're not at risk of seeing elevated above that kind of number. That's 2 micrograms per liter, not per deciliter, by the way. So stainless steel cookware, for example, there are cosmetics that are lead-free. There are spices. Most spices are lead-free. So it's not something you have to feel so terrible, too anxious about. There is definitely easy ways to avoid lead if you're just a little bit careful. It's doable.
Thanks for that positive note to end on. I think we'll wrap up the question and answer. And Drew, if you have some closing notes, closing statements.
Sure. Thank you, Megan. And let me start with our final minute or two here by thanking you for co-hosting and frankly for taking most of that role so that I didn't. Delighted to have ISCHE with us on this. And also thank you to our excellent panelists, all very interesting presentations. For everyone that joined us, a recording of this will be sent to all of our registrants, and it will also show up on Pure Earth's YouTube channel. And while we're plugging Pure Earth stuff, if you want to stay up to date with all of our other updates, there's lots of things going on. Join us. Our handle for social media is @PureEarthNow. You can also reach out to us at info@PureEarth and find our website at pureearth.org. We were talking about prioritization tools, and I just want to share something that we're working on We have, as Richard mentioned, pure leadpollution.org, and we are trying to build into it a tool where any person could build their own prioritization matrix in leadpollution.org by choosing different metrics, weighting them however you want, and then generating a prioritized list of countries, whether you care about mean blood lead levels, IQ loss, numbers of children above 5 or above 10, you'd be able to create your own prioritized lists based on your own weighted metrics. So stay tuned, hopefully, for that to come out this year. For folks that are interested in lead generally, the Center for Global Development has a lead working group, and you could sign up for that by contacting a gentleman named Rory Todd. I'll put his email in the chat here. He accepts new registrants for that working group at that email address. And check out the Partnership for a Lead-Free Future, which is a new body that aims to be a convening space for the lead community. So Partnership for a Lead-Free Future, that's housed at UNICEF, and you can Google that and sign up if you want to join that. And then Megan, back to you for closing thoughts on your side.
Thanks, Drew. Thanks, Pure Earth, for co-hosting. Thanks to all the panelists and presenters, and of course to the attendees for being part of the conversation. I think it's inspiring to hear how people across different disciplines are thinking intentionally and creatively about environmental exposures and child neurodevelopment or overall human health. I'm encouraged by the growing collaborations and the potential for continued momentum. If today's discussion resonated with you, I invite you to connect with ISCHE. We're a global inclusive community that's dedicated to advancing research, outreach, mentorship, and real-world impact. We have a very strong fellowship program that supports early investigators with training in scientific translation and outreach, with leadership opportunities. We have a long-standing collaboration with Little Things Matter, organization dedicated to raising awareness about the impact of environmental factors on children's health, particularly toxic chemicals on brain development. They're phenomenal at translating scientific research into accessible information. So please don't hesitate to reach out if you're interested. We'd love for you to join us, and let's keep the conversation going.